Good morning. My name is Christian Spaulding. I'm an interventional cardiologist working at the European Hospital Georges Pompidou in Paris, France, and it's my pleasure today to talk about the topic of coronary angiogram in survivors of out-of-hospital cardiac arrest. And the question is, when should you perform a coronary angiogram in these survivors? This talk will be mainly based on a study that was presented as a late-breaking trial at the American Heart Association a few days ago on November 14th, 2021, the EMERGE trial, and it was my pleasure to present the result of this trial on behalf of all the investigators of this very difficult study. So the background is that several registries have shown that acute coronary occlusion is a major cause of out-of-hospital cardiac arrest, and the same registries have also suggested that immediate coronary angiogram followed, if necessary, by a PCI may improve survival in these patients regardless of post-resuscitation ECG findings, in other words, including patients without ST segment elevation. However, until recently, randomized data was lacking. So we performed EMERGE, which is a randomized trial, and the hypothesis was that performing an immediate coronary angiogram after an out-of-hospital cardiac arrest without ST segment elevation on the post-resuscitation electrocardiogram and no obvious cardiac cause of arrest would lead to a better outcome versus performing a delayed coronary angiogram. And the primary endpoint of our study was 180-day survival with no or minimal neurological sequelae. So this is a trial design. Patients with an out-of-hospital cardiac arrest with no ST segment elevation were randomized to receive either an immediate coronary angiogram admission or a delayed coronary angiogram performed 48 to 96 hours after the admission. This was a study performed in France with 24 centers in France, and the key inclusion-exclusion criteria were relatively broad. Patients more than 18 years old with a return to spontaneous circulation without obvious non-cardiac causes of arrest, and who were admitted to a center with an intensive care unit and a 24-hour, 7-interventional cardiology department. The exclusion criteria: no return to spontaneous circulation, ST segment elevation, in-hospital cardiac arrest, absence of informed consent, and participation in another interventional study. This is the study flow chart. We actually had planned to include over 900 patients. Unfortunately, randomization was slower than expected. And furthermore, in France, when you do not reach 50% of your inclusion, the funds are stopped when it's a public study, which was the case of EMERGE. So therefore, we randomized 338 patients, excluded 59, mainly because of informed consent lack, and finally included 279 patients, 141 in the immediate coronary angiogram group, and 138 in the delayed coronary angiogram group. These are the baseline characteristics. There was no difference between the immediate and the delayed group, with a mean age of approximately 67 years old. The majority of patients were male with a witnessed out-of-hospital cardiac arrest with bystander CPR. Time from out-of-hospital cardiac arrest to basic life support was 3 in the immediate group, 2 in the delayed group, and the place of cardiac arrest was more often home, but also the public area. We had a high rate of patients with a non-shockable initial rhythm, 65.2 in the immediate group, 69.9 in the delayed group. There were signs of ischemia, ST segment depression, or negative T waves in approximately half of the patients. Procedural data. The coronary angiogram was performed in the immediate group in 126 patients and 74 in the delayed group. Actually, the main cause for not performing coronary angiogram in both groups was death before the patients could reach the cath lab. The time from arrest to coronary angiogram was 2 hours in the immediate group, 65 hours in the second group, and the radial approach was used more often in the delayed group. What is also interesting is that there is actually no significant disease in approximately half of the patients in both groups. PCI was performed more often in the immediate group compared to the delayed group, 30% versus 23%. And the reasons for not performing PCI were mainly either because there was no significant lesion or because a clear culprit lesion could not be found on the angiogram, and a drug-eluting stent was implanted in the vast majority of patients. So this is the primary endpoint between the two groups, immediate coronary angiogram versus a delayed coronary angiogram. There was no difference in survival at 180 days with CPC 1 or 2 between the delayed and the immediate group, and therefore we did not reach our hypothesis, which was superiority of an immediate coronary angiogram. There was no difference also in the secondary endpoints, where there was overall survival, the neurological sequels, the occurrence of shock during the first 48 hours, the occurrence of VTVF during the first 48 hours, left ventricular ejection fraction, length of hospital stay, or withdrawal of care. So the results of this study actually are similar to other studies that were published previously. There were 3 randomized trials that were performed on the same topic. This is the results of the COAC trial, which was presented and published in 2018, where they performed either an immediate or a delayed coronary angiogram, and there was no difference in survival. Note the differences of survival with our study. This is probably because they excluded patients with non-shockable rhythm. There was a smaller study with approximately 50 patients in each group that was performed in the US, the PEARL study, which also did not find any difference between immediate and delayed coronary angiogram. And this is the more recent study presented at ESC Tomahawk, performed in Germany, where there was no difference between delayed selective angiography and immediate angiography. So why are all these results from the randomized controlled trials on contrast with data from registries and survival of out-of-hospital cardiac arrest? There were over 6,000 patients that were included in registries on out-of-hospital cardiac arrest without ST segment elevation, which most of them showed that there was a survival benefit to perform an immediate coronary angiogram. And I believe that there's probably a need to perform a large meta-analysis to determine if there's a subgroup of patients which benefits from early invasive strategy. Probably what happened in these registries is that the patients which may have benefited from immediate strategy were included. There was a selection bias. And in one of our studies that was published several years ago, PROCAT2, we showed that the group of patients that has a clear benefit from an invasive strategy are male patients over 60 years old with a very short, low and no flow and a shockable rhythm. And this may be a group of patients which may benefit from a selected, from an immediate coronary angiogram strategy. So just to conclude on coronary angiogram and out-of-hospital cardiac arrest, when you receive these patients in the cath lab, whether it's actually immediate or delayed, I think it's the most important thing to do is to make yourself comfortable. What we do is that we don't jump on the patients to do the coronary angiograms. We check the intubation tubes, the cannulas, if patients have ECMO. We always have an anesthesiologist in the room. We check blood pressure, oxygenation, saturations, the lines before starting the procedure. We make the anesthesiologist comfortable before we start the procedure, and we always have an echocardiogram that is performed before. Radial or femoral, I believe that it's better to do it in radial. We leave the sheath, and if you do it in femoral, do an echo to be able to reduce the rate of local complications. One of the problems with patients with out-of-hospital cardiac arrest is really clearly define the culprit lesion. It's easy when there's an acute occlusion. It's more difficult if there's no occlusion. In that case, you look at the electrocardiogram and the echo to be able to determine which is the artery. But the most important is that in doubt, do not stent, since we have shown several years ago that the stent occlusion rate, the acute occlusion rate, stent thrombosis, is higher in patients with an out-of-hospital cardiac arrest, and this may be due to thienopyridine resistance in this setting. One word also about refractory cardiac arrest. What should you do when you get a call for a patient who has a refractory cardiac arrest? He has received several shocks. He still is in VT or most often VF. Should you bring these patients immediately to the cath lab? This has been tested in a study that was performed in the US where they highly selected the patients, young patients with no flow that was extremely short, patients who had low lactate levels when they came in, and they implanted an ECMO and did a coronary angiogram at the same time. And with this strategy, they have a high survival rate of 42%. In Paris, we perform a pre-hospital ECMO. In other words, if a patient has a refractory cardiac arrest, the SAMU, which is the pre-hospital emergency medical system, is called, and they implant a ECMO on site, in other words, outside of the hospital. And as you can see on the slide, we've planted it in numerous places. You can recognize the Louvre on the upper left. We've implanted it in supermarkets, in the streets, or even subways. What we published our first results in 2013, then we have been working regularly to be able to improve our results since we had a low rate of survival at the beginning. But since we have selected patients who are young with immediate resuscitation and with a protocol which allows implantation and running of the ECMO in less than 60 minutes, we have a 38% survival rate, which is excellent, but also remains to be demonstrated by a randomized trial. So, in conclusion, this is my opinion of the current status of a coronary angiogram in out-of-hospital cardiac arrest. If you have an ST segment elevation, you send the patient immediately to the cath lab and do the coronary angiogram. In patients without ST segment elevation, 3-4 randomized studies have demonstrated that you can defer the coronary angiogram and first admit the patient to ICU, and then discuss an emergent coronary angiogram if an ST segment appears, if there's a recurrent VT, VF, or there's shock. You should also include in the decision not only the opinion of the ICU physician, but also neurological prognosis based on age, duration of low and no flow, shockable or no shockable rhythm. And what do you do with refractory cardiac arrest? In specialized centers, you can discuss ECMO and coronary angiogram. One last word, the survival of